Moving on. So we were talking about our cephalosporins, right? And so we were talking about there's different generations of cephalosporins, and their coverage will change based on which generation you're looking at. So we talked about your gram-negative coverage is typically kind of increasing as you go up in generation. You'll find that first generation has pretty decent gram-positive coverage for things like skin flora, which is why we use things like cefazolin for surgical prophylaxis, right? If you're cutting into somebody, you have to really worry about that skin flora causing a potential opportunistic infection. But then you'll lose some of that gram-positive coverage as you go up in generation, and then now it starts to peak back up a little bit when you get to the fourth generation cephalosporins. And so the main one we're going to see here is called Cefepime, or Maxipime is the brand name. This is, again, a very broad spectrum antibiotic. You can kind of think of Zosyn, which is that piperacillin and tazobactam, and Cefepime is kind of having similar places. Like, so if you need a really broad spectrum kind of beta-lactam antibiotic, like these are one of the two ones you typically will go with. And I'll talk about a little bit about why you might use one versus another. But here you're going to see has really good gram-negative coverage. You're going to see has anti-pseudomonal activity, so that's another keyword there, right? Anti-pseudomonal coverage. Some gram-positive coverage, so you can get things like your strep pneumos, your staph epi, things like that. But you're not going to see MRSA coverage. And similar to other cephalosporins, you're not going to have enterococcal coverage, right? So no enterococcus gets covered by cephalosporins. Yes, sir.
I'm sorry, I missed that last point. You said it's one of two beta-lactams. What's the other?
Piperacillin and tazobactam, right? So that combination of the anti-pseudomonal penicillin plus that beta-lactamase inhibitor. And also no anaerobic activity here. So that's kind of the other key differentiator between this and Zosyn. And oftentimes we mention that you typically want to go with as narrow a spectrum antibiotic as you can. So unless you're really thinking that the patient might have a true anaerobic infection, you can typically, if you need broad spectrum coverage, you go with Cefepime instead of Zosyn. I see a lot of people go with Zosyn just because it is very easy to do. You just say, hey, I'm just going to give this, and I'll probably cover 95% of what the patient might have, but you're probably going to get better, less resistance happening over time if you use Cefepime as kind of one of your go-to for these broad spectrum antibiotics. So again, that's a big key difference between piperacillin tazobactam and Cefepime is that anaerobic coverage is one of the big ones. So when do we use this? It ends up becoming the drug of choice for neutropenic fever. Does anyone know what that is? Yeah, absolutely. So I'm glad no one the easy one is like, oh, when you have a fever and you're neutropenic. That is true. Yeah. So when you have immunocompromised patients, like cancer patients who are receiving chemotherapy, where especially like we see this a lot for our pediatric patients because leukemias are a very common cancer in that age group. So we end up giving them chemotherapy drugs, which will wipe out most of their white cells, right? So they end up getting neutropenic. Sometimes you can see this for patients who have other immunocompromisations, so if they have any kind of like primary immunodeficiencies or HIV/AIDS. Those sort of things, or kind of more progressive HIV. This is where you run into these patients who are neutropenic. And so when you are neutropenic, oftentimes you can have these infections that will start to boil up, but you don't really have the body's immune response to it. And oftentimes when you get sick, like that's what you're feeling is that body's immune response to that infection. So they will oftentimes only present, the only symptom they may be presenting with is going to be fever, right? So now you have a fever and you don't really know where the site of an infection is, and so you need to treat empirically, which is why we use broad spectrum coverage for that group, because we know their immune system is not very good, and we know that this will cover a lot of different bacteria. So this is why we use this drug for neutropenic fever very frequently. You'll see also used for a lot of nosocomial pneumonias, as I mentioned, things like hospital-acquired pneumonia, which is that HAP, and then ventilator-acquired pneumonia, or VAP. We use that very commonly. And then just for pseudomonal coverage, we'll use Cefepime, right? So things like ceftriaxone, being that third generation cephalosporin, being a very good go-to IV cephalosporin, pretty decent broad coverage. This is kind of a step above that, even broadening out that coverage further, giving you pseudomonal coverage as well, right? We actually have a few new ones, and so I'm just going to cover these briefly. Clinically, I've not used these too frequently, but I'll just kind of say them for completeness sake. We now have a fifth generation of cephalosporins, and so we have the ceftaroline or Teflaro. Again, with these newer antibiotics, what do you think the cost comparison is between these new ones versus some of the ones we have like on generic? Way more expensive, right? So this is another reason why we want to hold off on these. Is not only because we want to save their coverage and make sure they don't become resistant, but we also want to make sure we're curbing costs wherever possible. So we have this fifth generation ceftaroline. This has very good gram-negative coverage, good gram-positive coverage. Here you're actually seeing that there's still no enterococcal coverage. So that's still just a cephalosporin kind of idiosyncrasy there. This one's interesting because it actually covers MRSA. So this is kind of one of the first, really the only one of the few cephalosporins I know of that actually covers MRSA to some degree. So it is one of kind of a unique thing. Also covers anti-pseudomonal activity. So very few drugs cover MRSA and Pseudomonas. This is one of the few ones that do that. But again, no anaerobic coverage here. And you'll see, this kind of makes sense, the indications it has based on the coverage. So you think about community-acquired pneumonias, you're worried about things like your gram-negative bugs, you're worried about things like Pseudomonas potentially for some of these patients who are more at risk for these resistant bugs. But you see skin and soft tissue infections. And we mentioned what type of bacteria are typically causing skin and soft tissue infections. A lot of gram-positives, right? So you're thinking MRSA, you're thinking MSSA, you're thinking, things like that, things that live on the skin typically. Other things to note, it must be renally adjusted. Again, all of your cephalosporins need to be renally adjusted. Really, ceftriaxone is that one exception there where it's renally eliminated, or hepatically eliminated, sorry. Another fifth generation we have is this ceftolozane and plus tazobactam. You guys remember what that is? Tazobactam. Beta-Lactamase inhibitor, yeah. So again, this is another beta-lactamase inhibitor used to help broaden the coverage for cephalosporins. This is kind of an odd thing because you normally only see the beta-lactamase inhibitors with penicillins, but this is kind of an oddball. So ceftolozane, Zerbaxa is the brand name here. Again, when you add on that beta-lactamase inhibitor, you're starting to see that we have more anaerobic coverage. So it's kind of a thing you'll see in typical or with your immunopenicillins as well, is when you added on that beta-lactamase inhibitor, you saw greater anaerobic coverage, right? Which is why we use things like Unicin, which is ampicillin plus sulbactam. We use that for things like animal bites, right? Because we're worried about anaerobic infections there. So there's that. And you can see here with the FDA-approved indications, they do complicated intra-abdominal infections. What do you think complicated means? Not necessarily. Usually it's going to be more if it's like there's a complication, whereas you have like a perforation of the bowel or something. So you worry about a lot of those bacteria crossing from the bowel into the intra-abdominal space. Those are really the complicated intra-abdominal infections we're talking about. They tend to be more severe because, again, you don't normally have a lot of bacteria in the abdominal cavity. So when they get there, they are very easily able to make an infection. So we do that. We'll talk about another antibiotic called Metronidazole a little bit later on, but this is good for that anaerobic coverage, gram-negative coverage there. And then sometimes we use it for complicated urinary tract infections. Again, primarily gram-negatives you're going to see there. Again, for this one, the ceftolozane, no MRSA coverage. That really was on the ceftaroline. Okay, so that's it for the cephalosporins, right? So now we have our penicillins, we have our cephalosporins. Again, what was their mechanism of action? You guys remember? They have the beta-lactam ring. What does that do? Binds that penicillin binding protein. What does that do? Prevents us, the cross-linking from happening there. So you kind of disrupt that bacterial cell wall. Have lysis. You have the bacteria die off. So again, we're still seeing the same thing here. We have one drug in this next category called the monobactams, and this is called aztreonam. And you guys know you have to be able to draw this on the exam, right? Just checking. All right, just kidding. If no one's like secretly freaking out because it's like early and they didn't have their coffee yet. But anyways, this one's kind of interesting. It got its claim to fame because for a long time people thought that if you did have some degree of, if you had like a true penicillin allergy, for a long time people said, well, you can't get cephalosporins, and there really wasn't any good options to use for those patients because, again, you didn't have any penicillins, you didn't have any cephalosporins you could use. This one had its claim to fame for a while of having no cross-reactivity with a true penicillin allergy. So you can use aztreonam in those patients. Again, the cephalosporin cross-sensitivity is really overblown for the most part, so this drug doesn't get used very often anymore, this is aztreonam. Also, is very kind of narrow spectrum of coverage. It only covers gram-negative, so it really doesn't cover any gram-positives, any anaerobes here, but it does have pseudomonal coverage, right? So it has very good gram-negative coverage, but really nothing else. And you'll see when we talk about the spectrum, this is going to resemble our aminoglycosides, which is another class we'll talk about a little bit later in this this lecture here. Again, just note, again, it's going to be renally eliminated, so you do have to adjust for renal function. That does tend to go down. Again, still a time-dependent killer, just like all the other beta-lactam antibiotics are. Again, no specific allergies or adverse reactions to really worry about there. And again, can be used in this true penicillin allergic patients. Okay, next we have the Carbapenems. This is a very good group of antibiotics. These are very broad coverage. I call this gorilla cylinders because it's like, basically infections like dropping an Adabomb on them. Like you are going to destroy almost any bacteria you can come across for the most part. There's very good gram-positive coverage. Note here, no MRSA coverage. That's one hole that will not be covered here. Has very good gram-negative coverage, including the Pseudomonas. Sorry, Pseudomonas sounds like some kind of breakfast drink or something. Pseudomonas aeruginosa, except for Ertapenem. Ertapenem is one that we will not have coverage there, but certainly Imipenem, Doripenem, what was the other one? Meropenem. Meropenem is probably the one I clinically see used most frequently. Merum is the brand name for that one, but all of those will cover Pseudomonas. So we use those for very broad spectrum coverage. Think about those really sick pneumonia patients or sepsis patients where you're not sure what type of bacteria is causing the infection. You give this, it will cover almost everything except for MRSA. And it's also pretty resistant to hydrolysis from those beta-lactamases. So you don't have to add on a beta-lactamase inhibitor here. They're very resistant on their own, which is another kind of good thing why they retain so much activity there. So we use these for those multi-drug resistant gram-negative infections. One thing to note here is, and we talked about emerging resistance, and so one of the terms you'll hear is this ESBL, and that means extended spectrum beta-lactamase. Basically, when you have some of those space bugs, there's those escape bugs, things like Pseudomonas, Acinetobacter, they can produce these compounds that are even kind of more hardcore versions of beta-lactamase, and they can even start to break down some of these carbapenems. And so that's one of the things you look for. So say, for instance, you do a culture for your patient in the ICU, it comes back and it says Pseudomonas ESBL producing. You can pretty much be rest assured that things like the carbapenems are not going to work because that ESBL is going to break them down and make them ineffective. Okay. So you have to be mindful of that. Again, but this is very good coverage for nosocomial infections that you get in the hospital, and also we can use this for meningitis because it has pretty decent CNS penetration here. Again, note the time-dependent killing. You're going to have to give these pretty frequently for the most part. These are all going to be renally eliminated as well, so you do have to watch for renal function here. And one of the big things, also kind of the unique things to note here, is this Imipenem. Imipenem we do not use very frequently because we worry about the seizure risk. So for instance, if you had a patient who had poor renal function and they had buildup of Imipenem in the system, you can actually end up seeing seizures from that. So this is one of the reasons why we don't use that one very frequently. You don't see that with things like Meropenem or Doripenem. And again, Meropenem is really the only one that I ever use clinically. Okay, so that's it for the beta-lactams, right? So that's our cell wall active beta-lactam drugs. We're going to continue on the cell wall kick for a little bit here. Yes, sir. I don't know if they're actively trying to come up with any of those, but so far we don't have any on the market that are like you could add on, this to Meropenem and all of a sudden has like kind of continued activity. We don't have anything like that so far, unfortunately. Yep. And again, those carbapenems, you really want to hold off on those unless you really, really need it. Because again, when you have a really resistant bug, usually the carbapenems are your fallback drug, right? So if they're resistant to everything else, usually you can fall back on one of these carbapenems, and if you don't have that, oftentimes you don't really have a lot of good options to go with in those cases. So again, hold off on those, don't use them. And that's one of those things where I mentioned we have like a restricted antibiotic formulary. That's part of that antimicrobial stewardship where you have to have ID approval before they'll let you use Meropenem, right? So you may think like, oh, I'm the provider, I decide what I want for my patient. Really, you need to have that kind of expert guidance from the infectious disease people to come on and say like, well, maybe you should hold off, try this one first, see what the cultures come back, and then we can make a better decision on that later, right? So yes, sir.
For the carbapenems, when you said that you gave the example that it came back saying that it was ESBL reducing, and you said you wouldn't use the carbapenem.
I would not use an yeah. So if they're ESBL producing, you can pretty much be rest assured that it will say resistant to Meropenem and all those, right?
But it says drug of choice.
I'm so sorry. I was misspeaking there. I apologize. So expanded spectrum beta-lactamases, those are really good at breaking down things like the piperacillin and like your cephalosporins, right? So I apologize. Let me rewind.
Sorry.
Thank you for pointing that out. That's very good. The thing I was thinking are KPCs. Klebsiella producing carbapenemases, right? Because that's very specifically to break down carbapenems there. ESBLs, you can use the carbapenems for some of the ESBL producing things like Pseudomonas. You can't use things like Zosyn or Cefepime. It will typically be resistant to those. So you fall back on your carbapenems there. If that doesn't work, if they come back as their KPC producing, Klebsiella producing carbapenemases, and again, Klebsiella is the original bacteria that produced that. It can spread it over to other bacteria. So you can sometimes see Pseudomonas or Acinetobacter that is producing those KPCs because it just sends like a little bit of that DNA gets injected into the other bacteria. And so because of that, that's when you cannot use your carbapenem. So I apologize for that misspeaking there. It's very early in the morning, as you guys know. So anywho, any other questions? Thank you for catching me on that. All right. So continuing on, we have next have vancomycin. So what do you kind of notice about this molecule? Huge, right? So it's a very, very big molecule. Does not like to penetrate the CNS in a lot of cases, as we'll see. And so it's a very big molecule, and also we'll see some other kind of idiosyncrasies along with this. But this is vancomycin. Has anyone dealt with vancomycin before? Very common antibiotic we use in the hospital. Very good coverage, we'll see, against gram-positive bacteria. Anyway, so vancomycin is not a carbapenem. I'm sorry, it's not a beta-lactam drug. It's going to have a little bit different mechanism of action here. Basically, we'll call this as a glycopeptide antibiotic, but it's also going to be working on the cell wall. Essentially, what you'll see is it's going to bind directly to those two D-alanines. So you can see here, if you had, say, two layers of that bacterial cell wall that we're trying to connect up, this is that cross-link that would form. Normally, if you did not have vancomycin around, or if you had a vancomycin-resistant bacteria, you would still be able to see this crosslink happen, and then you would have the bacterial cell wall be intact, essentially. But what we see here is vancomycin can come along, can bind up to those two D-alanines, and prevent it from actually forming that crosslink, and then thus the cell wall is going to start to break down here. Sometimes what you can see as far as resistance goes to vancomycin is if they change out some of the amino acids that are there, vancomycin is not going to be able to bind to it very well. And so that's one of the ways you can see resistance develop, is by changing the targets, you make it so that the drug doesn't bind quite as well as it used to, right? So that's one of the things you can see when you have vancomycin-resistant bacteria. So vancomycin only is going to cover gram-positives. Does not really cover anything else. The one exception is it will cover C. difficile, right? So Clostridium difficile. Do you guys remember what type of bacteria that was? That's an anaerobe, yeah. So the only thing you'll see is that if you have a C. difficile infection, is that you may see oral vancomycin. Vancomycin is typically 99% of the time only ever given IV. Sometimes you will see oral vancomycin being given, and that's to treat C. difficile within the gut, right? Vancomycin being a very large molecule, how well do you think it gets absorbed through the GI tract? Not very easily, right? So because of that, we're able to give it in the GI tract, able to eradicate the C. diff infection, and then the patient clears, and they actually have no absorption of that vancomycin for the most part. I've had a few cases where that has occurred, but you will see that it's very nice from that standpoint because it doesn't get systemically absorbed. You don't worry about any toxicities. However, we most often are going to give this IV to treat gram-positive infections, especially when we're needing it for empiric therapy. So if you imagine a patient, say a little old lady coming from the nursing home, and I always go back to that little old lady scenario because that's usually the ones you see where they don't get watched very well, they get dehydrated, they end up getting septic, come over to the ER for treatment, right? And so you need kind of broad spectrum coverage because they've probably been on antibiotics recently that makes them more likely to have a resistant bug. You don't really know what they have, maybe a pneumonia, maybe it's bacteremia, you're not really sure yet. And so what you can do is you want to do broad spectrum coverage. And so one of the big things you want to cover for is MRSA, right? And so if you're treating MRSA, you need to usually end up going with vancomycin as your first stop. Because again, most of the time you're going to see that vancomycin is going to be able to treat MRSA infections for the most part. And then you're going to need coverage for Pseudomonas in those cases. So we'll talk about those, the coverages like when we get to the pulmonary section and whatnot, but just be aware that's usually those kind of patients where you're not sure what you're dealing with yet. You'll have that broad spectrum coverage against Pseudomonas and vancomycin. So we use Vanco, again, treatment of choice for MRSA. Sometimes we'll use this in surgical prophylaxis for true penicillin allergic patients. We cannot use, for whatever reason, if we can't use the cephalosporin or whatever, we can utilize vancomycin because, again, it'll still treat all that skin flora, no problem, right? Again, it'll treat C. difficile infection, so you shouldn't see a big risk for it to actually cause that in a lot of cases. And then it is also a drug of choice when we have things like endocarditis, osteomyelitis, which where does osteomyelitis show up? Yeah, so again, when you have those kind of really kind of nasty, kind of deep-seated infections of the bone, this is where vancomycin can have decent penetration, be able to get in there and actually treat that infection. And again, I mentioned surgical prophylaxis, usually just in the case of allergy, but it's very exceedingly rare that we'll do that. Actually, saw kind of an interesting case where some of our orthopedic guys, what they would do when they were, can't remember what specific surgery they were doing, but basically they're manipulating the bone for one of these patients. So what they actually would do is that vancomycin normally comes as a powder, and so we reconstitute it normally in the pharmacy and put it into a bag and then send it off for infusion to the patient. What they actually did is they requested a vial just for the powder. They would mix it in with this kind of like bone cement paste stuff that they were using and actually put that onto the bone on the patient, and that stayed there for a while. And the nice thing about that was it was able to release kind of small amounts of vancomycin very locally to get very high concentrations right there to kill off any potential opportunistic infections, whereas you didn't have to give it to the patient systemically. So that's, sometimes you'll see kind of weird things like that. If you ever go work in ortho, you may see that potentially. So this is one of the drugs we do therapeutic drug monitoring on, right? So because, and why do you think we might do therapeutic drug monitoring? Yeah, narrow therapeutic index, absolutely, right? So and we don't want to get too high for these levels because we can potentially see toxicity, and also we don't want to have the level too low because then what happens? You're not treating the infection, right? So you're going to have the bacteria continue to grow, because again, this is still going to be one of those time-dependent killers, right? So it needs to be above that MIC for a long enough period of time to kill those bacteria off. So what you can see here is that we will shoot for, you can see the dosing we kind of use. And again, usually depending on the patient, you say every 12, every 8 hours, depending on what their kidney function is. And again, this is renally eliminated. That's another reason why we have to do the TDM, because if their renal function starts to suffer, if it changes, they may not be clearing this drug as well, or they may be clearing it too well. The levels get too low. And what you can see is we'll actually shoot for a gold trough. Now, why do you think we look for a trough instead of a peak? Yeah, because we need it above that MIC. So if I were to use a pin here, so if I was to look at the time here being on the x-axis, having the drug levels here on the y-axis, if I had the MIC of the bacteria, what I'm doing is I'm giving the vancomycin. Again, I want to make sure that when it gets to steady state, that the trough is staying above that MIC. I don't really care what the peak levels are so much because it's not one of those concentration-dependent killers. What I really care about is making sure that trough is staying above the MIC there. So that's why I only measure troughs for vancomycin. We'll see that it's not the case for some of the other antibiotics, but this is the case for vancomycin here. So anyway, so again, we will shoot for gold troughs. So depending on the type of infection we're dealing with, we may shoot for something like 10 to 15 mics per ml, or if we're dealing with more severe infections, we'll shoot for 15 to 20. And I mentioned vancomycin is a very large molecule, has a hard time penetrating certain types of tissues. And so some of the reasons why we might shoot for higher troughs are for things like pneumonias, right? Usually the lungs are kind of notorious for trying to penetrate and getting those bacterial infections. The CNS for trying to get through the blood-brain barrier. The idea is if you have a higher level within the blood, as a surrogate marker, you should have higher levels at the site of infection, whether it be the lungs, the brain, whatever it happens to be. That's why we shoot for those higher troughs when we're measuring these blood levels, right? And so one of the things you'll see is that you can still have resistance to vancomycin that can develop over time. And so if you have the MIC, the bacteria become too high, that's when you have to go to one of our fallback drugs, right? And so we'll see what some of those fallback meds are going to be. Linezolid is going to be one of the ones we'll talk about there. But. And again, how long does it take to get steady state? 4 to 5 half-lives. And so one of the biggest things I see people do, especially if they're not used to doing vancomycin kinetics, is that they will check a level too soon, right? So if I check a trough and I end up checking it, say, after the first or second dose, what do you kind of notice about the level? Is it going to be too high or too low? Too low, right? So the level's too low, and then you say, okay, well, the level's too low, I need to go ahead and up my dose, right? Or I need to give it more frequently. And then what happens when you get to the new steady state? Now it's too high, right? Now we start to worry about toxicity. So that's one of the big things. You always want to check this a trough for vancomycin before the 3rd or 4th dose. By then, at that point, you're relatively sure that you're going to be at steady state. You know that you're not checking it too soon, and that the level should be relatively accurate, right? You guys remember any of those other kind of caveats with time when you're doing therapeutic drug monitoring? Exactly. And you know when the drug's given, and then also you need to know when the level was taken, right? So you need to be able to have that good communication, make sure the documentation is done well by the nurses. That's one of the big problems we run into, where the levels come back and they don't look right. Oftentimes it's because either the drug was given late or too early, or the level was done too late or too early. And so we have to kind of extrapolate and say, like, well, had they waited long enough to get the trough, it would have probably been something like this. And so again, this is one of those little things you kind of fudge your eyes a little bit and say, like, oh, this is probably okay, and you kind of go with that. But in most cases, as long as you wait to that 3rd or 4th dose to get that trough level, and again, you check it right before the next dose is given, you should be at steady state and should be a relatively accurate level. So again, looking at vancomycin, actually what we'll do sometimes for these patients is give what we call a loading dose. Do you guys remember what the loading dose is used for? You try to get to steady state faster. So sometimes for critically ill patients, what we can actually do is give them a larger dose up front. And again, you don't have to memorize the mg per kilo dosing or anything by any stretch of the imagination. But just know that we'll give a bigger dose as a loading dose to try to get them to steady state faster, to get those levels up to treat that infection much more quickly. Because again, these patients may be very, very sick, and you need to get above the MIC as quickly as you can in order to make sure you're treating them effectively, right? Also, what we'll see is that the dosing interval changes pretty greatly depending on the patient's renal function, right? So say, for instance, they have really good renal function, creatinine clearance is estimated to be above 70 mLs per minute. You guys remember what equation we used for that to determine creatinine clearance? Cockcroft-Gault is one of the most common ones we'll deal with. Again, depending on if you're dealing with pediatrics or the really elderly patients, sometimes you might use different ones. But Cockcroft-Gault is good for most adult patients. And again, if you think about anything over 100 is typically considered to be pretty good. And so for these patients, anything greater than 70, you can get away with giving Q8-hour administration. I can give it every 8 hours, and that should keep my trough levels above that MIC. And then as you start to see the creatinine clearance start to drop, say 50 to 70, now we're giving it less frequently, right? Because that means if their creatinine clearance is lower, we're using it as a surrogate to say, well, they're probably not clearing the drug as well. So now we're going to give it every 12 hours. As it starts to drop even further, we can say, okay, well, let's give it every 24 hours. You guys ever heard of the term CRRT? Stands for continuous renal replacement therapy. That's basically where we are putting the patient, and you guys have heard of hemodialysis before? Basically where we put the patient on a machine that will cycle out the blood, put it back in and it removes all the waste products. That is usually done as an intermittent process. You'll see a lot of patients be on it, say Monday, Wednesday, Friday for about 4 hours or so. CRRT is something you may see being done like in the ICU, where basically they're putting on a continuous machine where the CRRT machine will continuously be filtering the blood out, getting rid of a lot of those waste products. So basically it's like the patient has normal renal function, it's just being handled by a machine, right? Which we could also hope to eventually machines take over most of our bodily functions, at least I do. But this is one of those cases where we use it for really the sickest of patients. And sometimes what you'll actually see is we may only do kind of this random intermittent dosing where, say, for instance, a patient's getting intermittent dialysis, say every couple of days or so. What we'll actually do is we'll give them one dose. We know the patient's not making any urine. We know they're not clearing any of that drug. And then we'll wait until they get dialysis. We'll check a level, see how low it is, and then redose them at that point. So again, there's a lot of kind of there's a lot of art and some science to this. But again, this is why it's really good to have a good interprofessional team that can help to monitor this. So either your ID team that's consulting on this, your pharmacy who can help you with the dosing and checking levels and all of that. And in a lot of places, you'll find that there's a pharmacy protocol set up to where they will handle all of that for you. They'll do all the levels, they'll do the orders, and may call you and say, hey, just to let you know everything's going all right, or the patient is not doing okay, here's what I want to do, and blah, blah, blah. So you'll see that come up with some frequency in the hospitals. So the reason why we do all this is because, one, we're worried about efficacy of the drug. We're also worried about toxicity. Biggest things you're going to see here is that vancomycin undergoes renal clearance almost entirely. And if you have the levels get up too high, we run the risk of encountering what we call Odo Toxicity, which is, what do you think that is? Yeah, so you can see hearing loss that can occur. Basically, kind of like high frequency hearing loss that happens because the levels build up and they're toxic to those hair cells. Right, you guys remember going over all those hair cells and stuff. I don't know if you have any like kind of vestibular problems. I've never seen that reported, but certainly high frequency hearing loss has been reported there. Nephrotoxicity can be another thing where you can see an acute kidney injury that can develop. Oftentimes, these patients are going to be on other medications which are also nephrotoxic, so sometimes you're going to see some synergy there. And also, when you think about a septic patient, right? Have you guys covered like anything about sepsis yet? Right, so when they get bacterial infection in the bloodstream, they get very, very inflamed. You oftentimes see that they become hypotensive, right? Because a lot of the blood vessels end up dilating. You third place a lot of fluids, you get hypotensive. And we mentioned, where does the body primarily want blood to go? Brain and the head, right? So because, I'm sorry, the brain and the heart. So because of that, brain and the head are pretty close together. So anyway, so the brain and the heart. So essentially what you see is that the kidneys take a kind of a back seat to that. So you can have renal hypoperfusion that happens for those septic patients, and they end up having not only this extra drug load on board that can cause toxicity, but they also have kind of poor perfusion. So the kidneys, we saw they are very oxygen dependent. They require a lot of energy to cause all the appropriate reabsorption and secretion, all that good stuff. That takes a hit, and that can lead to further kidney injury. So when you have these ICU patients and they're hypotensive and they're on vasopressors and all of that, you have to monitor for their renal function very, very closely, at least every 24 hours, sometimes every 12, depending on how severe they are. So, and again, if you think about it, if you have an ICU patient who's ventilated and they're sedated on the when they're intubated, are they able to tell you that their hearing is going? Or they have any kind of muffled hearing or anything like that? Oftentimes they can't, right? So that's why we use these drug levels to make sure the levels are not getting too high, they're not accumulating too much, because a lot of times the patients may not be able to communicate that they're having any kind of hearing dysfunction there. Anyway, other things you can see with vancomycin. We spend a lot of time on this just because we use it so frequently and it has so many kind of idiosyncrasies with it. But we have what we call red man syndrome. And so this is a case where if you infuse the drug too quickly, the patient can have a very pronounced flushing effect that happens. They get itchy, they get red, they feel very hot. This is not a true anaphylactic reaction, right? This does not mean you cannot receive the drug. It just means we give it too fast. So what we frequently do, we'll slow down the infusion time. And instead of giving, say, the drug over 30 minutes or an hour, we may actually give this drug over 2 hours, right? So by slowing down the infusion time, you can deal with that reaction. And sometimes patients still have a reaction at 2 hours. So we'll actually give it over 3 hours in some cases. It's not ideal, but this is the only way to prevent that reaction from occurring there. Vancomycin is kind of interesting because they used to call it Mississippi mud. Because the formulation of it had all these kind of impurities and things like that. This is back like in the 70s, 60s, and 70s. Had all these impurities and it had this kind of brownish kind of color to it. So again, I would not want anything called Mississippi mud being infused into my veins. But nowadays, it's much more pure, so you don't really see as many problems with that. So again, we need to do that therapeutic drug monitoring. We're going to be measuring the troughs only, never really doing the peaks. We don't really care about that so much. Okay, I mentioned doing that before the 3rd or 4th dose to ensure that we are at steady state. And again, you'll do those troughs roughly 15 or 30 minutes before the next dose. And again, most of the times you'll see either a gold trough, depending on the site of infection, you may see 10 to 15, 15 to 20, depending on that. I'm not going to ask you specifically the levels that you're shooting for, because again, you guys can look that up when you're dealing with it. Or and in a lot of cases, when we have vancomycin being ordered in the hospital, we have a lot of that set up. So where basically you'll answer questions. If you're doing like an electronic medical record system, it'll say like, what are you treating? It'll say osteomyelitis. It'll say, okay, you want to shoot 15 to 20. Or if you're treating for meningitis, okay, 15 to 20, whatever it happens to be. So. All right. Some examples of some red man syndrome that can pop up here. So again, not a true anaphylactic reaction. This is not a contraindication to receiving vancomycin. You just need to run it more slowly.
Worry about that with a critically ill patient.
Not necessarily. You don't really see hypotension develop along with that. Certainly they get very flushed and they get very hot. But as long as you slow it down, typically they do just fine with it. Yeah. Okay, so that is it for our cell wall inhibiting drugs. Now we're going to move on to the protein synthesis inhibitors. So there's a wide group of medications that are going to affect the protein synthesis here. And so basically what we see, and why do you think that antibiotics are specific for bacteria and they don't really affect our cells? Yeah, so in this case, we're looking at the ribosomes. We have different types of ribosomes, right? So the structure is different enough to where the drugs are specific for those and the bacteria, but not for us, which is nice because there's some degree of specificity there. Just like you'll see with cancer drugs are very specific for human cells. And so that means that it will kill cancerous cells, but it'll also kill healthy cells as well, which is one of the problems we see with a lot of chemotherapy. But the nice thing here is we have some specificity. This limits a lot of the toxicity you may see. So you don't really have your proteins being inhibited here, but you'll have the bacterial proteins being inhibited. A lot of it goes back to the ribosomes that we express here. So bacterial, they have this 50S and 30S ribosome. For mammalian species, we have 60S and 40S. So they're different enough to where the antibiotics should not be interacting with one another for the most part. Really just treat these bacterial infections. So what we'll see is that some of these are going to bind to the 50S ribosome. Some of these are going to be 30S binders. I'm not going to ask you specifically if it's a 50 or 30S. Just know that it's a protein synthesis inhibitor. That'll be enough for me. I'm just saying it here for completeness sake. But basically, you guys remember how we synthesize protein. Remember that the DNA is going to be copied over. It's going to turn into mRNA, and that has to be shuttled over to the ribosomes where transfer RNA can bring in the amino acids. It can read those codons there and be able to generate new proteins. If I inhibit this process here, we'll see some different ways we can do that. You will prevent new functional proteins from being made, and thus you're going to have the bacteria not really able to reproduce as it normally would. For the most part, most of these protein synthesis inhibitors are going to be bacteriostatic. You'll see some exceptions where they will be bactericidal, like aminoglycosides are a good example of that. But for the most part, they're going to be bacteriostatic, not really having such a profound effect as like disrupting the entire cell wall as you would see with like a beta-lactam or vancomycin. Okay, so the first group we'll talk about are going to be our macrolides. So this is a very popular group of antibiotics we're going to run into. So again, this is going to work by binding that 50S subunit and inhibits that protein synthesis. Basically, you prevent that transpeptidation, so you prevent kind of elongation of those proteins when you have that there. The three drugs we have in this category we'll talk about are going to be erythromycin, clarithromycin, and then azithromycin. Anyone heard of azithromycin before? Yeah, everyone's heard of Z-Pak, right? Erythromycin, anyone heard of that before? You ever had like a corneal abrasion or something and had some erythromycin ointment? Yeah, so that's probably the most common place you'll see that being used. You'll see that most of these are given orally. Erythromycin, again, I mentioned, has topical preparations you can use, especially like in the eye. We'll talk about that when we get to the ophthalmic section a little bit later on. Some of these will have IV formulations as well. So we don't use these drugs IV very commonly. These are much more commonly given via the oral route. And so probably azithromycin is going to be the most common one you'll see being used. Probably way too often is it going to be used because a lot of people come in and say, oh, I got sinusitis. And most of the time, what's the cause for sinusitis? Virus, right? And so they say, okay, well, here's a Z-Pak. Go ahead and take this and see if you feel better. And sure enough, they feel better anyway. But now they've taken the Z-Pak along with it, and so they're curtailing further resistance and all, or promoting further resistance. So this is one of the big things we see a lot of overuse of. This, and we'll see with our fluoroquinolones, a ton of overuse of things like Levaquin and Cipro. And we'll see in a little bit. As far as coverage goes, macrolides are good for covering some gram-positive aerobes. So we can see things like strep pneumo, we can see things like MSSA, so no MRSA, just MSSA, strep pyogenes, listeria. It does not cover enterococcus, but it gets a lot of these good upper respiratory tract bugs for the most part. So things like your strep, and also this will be good for a lot of pulmonary infections as well. So the other kind of interesting thing that it covers is going to be our atypicals, right? So it will cover Legionella, cover things like Mycoplasma, chlamydia. It also has decent gram-negative coverage here as well. So things like H. flu, Moraxella catarrhalis. And again, I just note here that azithromycin probably has the best coverage out of the whole group, which is why we use azithromycin so often, right? Because it typically has the best coverage for things like Moraxella catarrhalis, Neisseria. And so basically, this is really kind of tailored to treating a lot of these respiratory tract infections, both upper and lower. And so that's probably most often where you're going to see them. Because again, when you have these older, say like an adult patient, you worry about atypical infections, especially like atypical pneumonias. Often that's what they call the walking pneumonias when you'll learn about that. And so typically it's going to be caused by things like Mycoplasma, potentially Legionella. So this is where we can treat those with the azithromycin. Right? So anyway, so decent coverage, no anaerobic coverage here, but we'll cover a lot of respiratory tract infections for the most part, which is again why it gets overused so frequently. So we will use this for community-acquired pneumonia. We can use these for acute otitis medias, pharyngitis, tonsillitis, sinusitis, chronic bronchitis. So if you got an itis, this will probably treat it, as long as it's in the respiratory tract for the most part. Very occasionally, you might use it for skin soft tissue infection, but not super frequently. And the other nice thing is it will cover some opportunistic infections. So you guys ever heard of MAC, or Mycobacterium avium complex? This is a opportunistic infection you may see in more severe AIDS patients. You'll see, and again, when you're monitoring HIV patients, you guys know what type of cell count you're looking for? Yeah, you're looking for CD4 cell count. So you'll see that drop as their disease gets more progressive, as the virus continues to replicate and destroy those cells. So as you see their CD4 drop, they become more and more likely to develop certain types of infections. So like at 200, they're more likely to get things like PCP pneumonias. As they get down to like 50, this is where you start to see things like Mycobacterium avium complex. We are probably exposed to this all the time, but we have a competent immune system, so we can fight that off pretty easily. These patients cannot, though. And so this is where something like the macrolides can come in and be able to be used to treat things like this MAC complex. Also things like chlamydia, and also, you guys ever heard of H. pylori? I mentioned that before. What does that cause? Yeah, stomach ulcers specifically. So this is also going to be one of the components for if you're treating H. pylori infection in the stomach, causing all the stomach ulcers there. Did anyone ever go look up that documentary I talked about with the Australian doctor who discovered it? Pretty cool. There's some short YouTube videos, but he got a Nobel Prize off of it because he gave himself an H. pylori infection and then antibiotics and treated it. It was very, very interesting. Anyway. So some of the adverse effects you're going to see here is that you're more likely to see a lot of stomach upset and diarrhea associated with the macrolides. You see this more often with the erythromycin, and especially like in children and young adults. The thing here, and we actually use this therapeutically, is that you'll find that erythromycin works on what we call motilin receptors, which are located in the GI tract. And when you stimulate motilin receptors, what happens, do you think? motility, right? You see increased peristalsis, essentially. And so we can actually use this for some patients who have slow GI tracts. They have gastroparesis with some diabetic patients. So we can use this therapeutically to help kind of stimulate the GI tract. But this is also going to be an unintended side effect for patients being treated with these drugs for infections. So again, stimulates motility, likely to see diarrhea and things like that. It's not the same as like a C. diff diarrhea where you have like really watery, foul-smelling diarrhea. This is just normal diarrhea. And so, again, some risk for allergic reactions here, some rare cases of hepatitis, and then typically you don't really see a ton of problems with these drugs. But you may see some hearing loss if you're using like really high dose IV, but we don't use that very often. The one thing I would note here is that you see this QT prolongation. When I say QT prolongation, what does that mean to you? EKG, right? So you think EKG, think what was the QT interval? What was that showing you? Ventricular repolarization. That's a key thing there, right? So ventricular repolarization, which you can see if you have drugs that are blocking. Typically, these are blocking potassium efflux channels, right? You block those channels, you can end up seeing a prolonged QT interval, and that will lead you to have more risk for certain types of arrhythmias. And primarily, it's going to be torsades de pointes. Probably not saying that appropriately. If any French-speaking students may be able to help me with that, but torsades, we'll call it that for short. You will see that this is much more likely to occur when you have a prolonged QT. The drug by itself, you can probably give Zithromycin to a ton of people and they're not going to have any problems with it. So when you add on multiple drugs, it can all prolong QTs when you have an issue here. Or if you have a patient who has a genetic predisposition to prolonged QT, some of them will have mutations in their potassium channels where they just happen to have a prolonged QT at risk baseline. This can worsen that. So be careful with that. If you have any patient with a cardiac history, kind of investigate for something like that, and be careful if there aren't other drugs that also prolong the QT interval. Also, if you have, you normally see like antiarrhythmics can be one of the things that can exacerbate this, but also electrolyte abnormalities. So if you had things like hyperkalemia, hypokalemia, that can all potentially put you at risk for that. And again, if you think about it, if you're extending out that repolarization period, what do you have the risk for? Just remember that absolute and relative refractory period, right? Which one is able to be triggered if you have a high enough signal coming in? Yeah, so you extend the relative refractory period, so potentially you can run the risk of having reentrant rhythms coming in, and so you get this really kind of crazy arrhythmia that happens. If you can look up pictures of torsades and kind of see what it looks like, it's very kind of unique. So other big thing, CYP interactions. You guys remember cytochrome P450? You guys blocked out those memories? Hopefully you remember it, because this is going to come up again and again and again and again. CYP interactions are big for the macrolides. So primarily you're going to see erythromycin, followed by chlorothromycin, and finally azithromycin, probably being the least offensive one here. But it will bind to and inhibit CYP3A enzymes, right? You guys remember what the most common CYP enzyme we run into is? 3A4, right? So this means that 3A4 is going to be inhibited when you have these macrolides on board, okay? So that means that if a other drug you are on happened to be metabolized by CYP3A4, what happens to the levels of that drug? Going to increase, right? Because I'm inhibiting that enzyme there. I'm inhibiting the metabolism of it being metabolized. So this means that you can end up having increased levels of these CYP substrates, things like certain anti-epileptics like carbamazepine, certain cardiac meds like digoxin, Versed, or midazolam, which is a benzodiazepine, used as an anti-seizure medication. So lots of things. Make sure you check their profile before prescribing. You're more likely to run into issues with this more so than you are the QT prolongation. But again, those are big things to note as being unique things with the macrolides. Okay. Again, this is just an example showing this drug-induced QT prolongation. So essentially, you have these potassium efflux channels, right? So this is extracellular space. Here's intracellular. Normally, you'd have potassium leaving the cell, and that was leading to that that repolarization phase you can see there. And so by extending that, you're going to have more likely to have those kind of reentrant arrhythmias happening due to that absolute or the relative refractory period being extended there. And so what you can see here, what this would look like on the EKG here would be normal versus the prolonged QT you can see. So notice it just takes a lot longer for that repolarization to occur there. Okay. So that's it for the macrolides. Next, we have the tetracyclines. So this includes the drug tetracycline. We'll also have doxycycline and then minocycline. Again, a very common group of medications. Doxy is probably going to be the most common one you're going to run into on a clinical basis. If anyone goes and works in the derm field, you'll probably see a lot of doxy being prescribed. This is, again, going to be a protein synthesis inhibitor. Again, binding that 30S ribosome, basically going to be preventing that tRNA from binding to this A site here in the ribosome and causing, inhibited protein production there for the bacteria. Again, these tend to be bacteriostatic, and they're also going to be potentially pretty broad spectrum, as we'll see in just a second here. So again, pretty good coverage, pretty much green across the board. You'll find that tetracycline and minocycline are going to be PO only. Sometimes we use doxy IV, but for the most part, the tetracyclines are given orally. You're going to find that it has very good coverage for atypical bacteria. This will also cover certain animal-borne organisms, so things like Yersinia pestis. You guys know what that causes? The plague. Yeah, so Yersinia pestis gets covered there. Things like Brucella, Borrelia, Rickettsia all get covered with doxycycline. So you'll see, like, if you're taking like your micro class or you're taking like the ID block of CMS, it's like, the patient's out in the woods and they end up getting some weird infection, like probably doxy is going to be the drug to go with for 9 times out of 10, I would say. Also have good gram-positive coverage. You see sometimes we'll cover some strains of MRSA, Enterococcus, common gram-negatives, some anaerobes, Treponema palladium, H. pylori, all kinds of good coverage here. So it covers pretty much lots of different things. We don't use it all that commonly for a lot of these infections due to some of the toxicity, as we'll see in a minute here. Will not cover Pseudomonas, does not cover C. diff. So those are going to be some notable lacks in coverage that you'll see with the tetracyclines. So where do we see these used most commonly? We do see it used for acne very frequently. So again, if you're in the derm field, you may see this being used as an oral antibiotic used to treat more kind of moderate to severe cases of acne, as we'll see in the derm section coming up next. You can use this as an alternative potentially to the macrolides for atypical pneumonias, right? So caused by some of those atypical things like mycoplasma. And then a lot of animal-borne diseases. So you see things like Lyme disease or Rocky Mountain spotted fever. Those can also be treated by doxycycline and the other tetracyclines. And chlamydia can also use it for certain STDs as well. Drug interactions to note here. This chelates with cations, meaning that it will bind up things like iron and calcium, which means that the drug will be less likely to be absorbed. So this is one of those big drug-food interactions. You can let patients know, don't take it with milk. Look out if you're taking it with multivitamins that contain iron and things like that. That will lead to less drug being absorbed and less likely to have eradication of that infection. Other things you can see, these are important contraindications, is we do not give doxycycline to patients less than 8 years of age, and we do not give it to pregnant women in general, but most likely in the second and third trimester, we do not administer to them. Okay, the big thing here is you can see this discoloration of the teeth. So again, by the time you're 8 years old, chances are you had all your adult teeth come in and you have pretty much all that calcium already being set. If you have it before, then you can see that there's some discoloration, kind of yellowing or browning of the teeth that can happen there. This also happens to the bones and can potentially cause some bone or some stunted skeletal growth, which is why this is contraindicated for pregnant patients. Okay, so again, avoid less than 8 years of age. In general, just avoid pregnancy altogether, but mostly second and third trimester. Also, has to be renally dose adjusted, so just kind of watch out for that. With the macrolides, I didn't mention any renal adjustment. You don't really have to do it for those, which is kind of a nice thing. You don't have to worry about renal function for those guys. Okay. Next, we have the glycylcycline class. There's only one drug here. It's one of my favorites called tigacycline or Tigacyl. And you'll if you look at the structure, it kind of looks like a tiger a little bit. It kind of has 4 rings with 4 legs on it. And a lot of the marketing actually had tigers along with it. You'll see why in a second when you look at the color of the drug. Anyway, Tigacyl is a drug you may see used just occasionally, probably more in the ICU, more than anything else. But again, it's blocking protein synthesis here by working on that 30S ribosome. And it's, again, another bacteriostatic agent. Very good coverage here. And one of the big things you're going to see is it is used for a lot of complicated skin infections and also some intra-abdominal infections. So usually this is going to be a fallback drug after some of your other drugs have failed. So we see things like E. coli, E. faecalis. This is VRE stands for vancomycin resistant Enterococcus. So again, you can't use it for that, but MRSA, other kind of other staph groups, and then you can also use it for a lot of these complicated kind of gut infections and things like that. So wide range of coverage. But we do not use it too frequently because one's expensive, and also we'd like to keep our coverage as best we can to prevent resistance from developing here. Notice it's going to get things like Klebsiella. It's going to be able to, I can't remember if it has, but it definitely has MRSA coverage, but it doesn't really cover Pseudomonas necessarily. But what it can do is help to cover some of those KPCs, or those Klebsiella-producing Carbapenems. So sometimes you'll see a patient who will be on Imipenem. The infection is not really going away. You have your culture come back and it says KPC producing. You can eventually switch over to tigacycline potentially, as long as it maintains activity. This is a nice bright orange color, so you can see why a tiger kind of got a lot of marketing. So there's a really cool ad where like a doctor was walking down the hallway and like a big tiger next to him, and I thought that was the coolest doctor I'd ever seen. Unfortunately, it does not exist. But anyway, again, no renal dysfunction you have to really watch for here. Maybe a little bit of hepatic dysfunction, but again, for the most part, it's pretty well tolerated. No significant adverse effects other than the typical GI upset.
So what do you want us to know, like, for dosing? Because I remember you saying like not to focus too hard on the dosing.
Yeah, I'm not going to have you guys be able to know, like, okay, well, what's the loading dose for tigecycline? Like, I'm not going to ask you those sort of things. But it may be like, this drug is considered to be a time-dependent killer. How often do you think it needs to be given? Maybe like Q24, Q48, or Q6 or something. You say, okay, well, probably give them Q6, right? Concepts like that are important to know. But again, I'm not going to ask you. I may include doses on the answers, but I'm not going to be testing you on that. I'm just trying to let you guys see that so you kind of get more familiar with seeing it. So it'll be more important for things like antihypertensives and cardiovascular meds. So you can at least get used to what a normal dose is. So that way you're not like, let's give 5 grams of digoxin. Like, that's not right. So you can at least be familiar with some of that stuff. Don't ever get 5 grams of digoxin. Your patient will probably be dead. Any questions from the first half? All right, so we're going to continue on with our aminoglycosides. So 3 drugs in this category. We're going to have amikacin, gentamicin, and tobramycin. And these are pretty common ones we're going to use in the hospital, especially for more severe infections, especially a lot of pulmonary infections or sepsis. You're going to see these very, very frequently because these really good gram-negative coverage, and that's about it. Very good activity against things like Pseudomonas, a lot of Enterobacter Ssri, E. coli, Klebsiella, Proteus, Serratia, all that good stuff is going to be covered with your aminoglycosides. So we use it very frequently for those purposes. Enterococcus here, it will have some coverage, and this is actually a special case where we are going to use this for synergy only. When I say synergy, what do you think that means? Yeah, using like 2 drugs together to actually cover that. This is going to come up when we get to the cardiac section, so don't stress on this one too much. We'll cover that again when we get to endocarditis. Again, we used to give this drug more frequently, every like 8 hours or so. In rare cases, you'll still see that, but this is one of those a good example of a concentration-dependent killer. And so we know that because of that post-antibiotic effect, we can shoot for really high levels, get the level really high on the patient. Let me just draw this here. Get your levels after you give a dose pretty high, and then basically just let the level trail off. So even though it drops below the MIC for the bacteria, and you're not dosing again for say another 24 hours, you're still going to see that post-antibiotic effect. You're still going to have some bacterial kill that's happening there. And so what the nice thing about doing this Q24-hour dosing is that your level will be negligible by the time you're giving the next dose. So you don't really see a lot of buildup there, and that's going to be important for a lot of the toxicity we're going to look at when we talk about this. So just know that we're going to get this much less frequently, usually every 24 hours or so in a lot of cases. We will use this most commonly for cases like febrile neutropenia. We kind of mentioned that before. We talked about Cefepime previously. You'll use this in sepsis, kind of those kind of overwhelming kind of body-wide inflammatory reactions, usually the bacteremia and things like that. And then I mentioned that enterococcal synergy, which I mentioned for like endocarditis, which we'll talk about much later in the class. Big things to know here. This is another one that we do therapeutic drug monitoring on. So again, similar to vancomycin, this is the other most common one. And guess what? A lot of times you give vancomycin along with one of these aminoglycosides because when you have a patient who's severely ill and you're not sure what's causing it, you want to cover for MRSA and you want to cover for Pseudomonas. So these are very frequently given together. And so often you're doing therapeutic drug monitoring on both of these at the same time. The reason why we do that is because we're about things like renal toxicity. So again, we saw with vancomycin, that can also cause renal toxicity. So these can be synergistic in that regard. And again, when you have a really sick patient, you also worry about that renal hypoperfusion as well being a problem. These can also be ototoxic. So you can see that synergy there. And you really have to renally adjust that. So we really look at the patient's renal function to determine, do they need every 24, or maybe I need to give every 36 or every 48 hours in some cases. So that's one of the things you may consider when you're doing monitoring your levels there. So again, usually we're going to be giving these drugs at higher doses just once daily in order to get that post-antibiotic effect and get that really high concentrations to kill off as many of those bacteria as we can. And then normally when we're checking our troughs here, when you give Q24-hour dosing like that, you're giving such a big dose, your peaks are going to be high, right? There's no point in measuring a level of that because you already know it's going to be high. But again, here what we're going to do is actually measure our troughs because we're not necessarily making sure that the trough level is above the MIC for the bacteria, what we're actually want to make sure is that the patient's clearing it appropriately. So it's kind of another reason why we're looking at the troughs, to make sure that it's not building up. So typically what we'll see is we'll look for troughs, say, less than 1 or less than 5. Usually we like to see undetectable, as the laboratory result will come back and say undetectable levels. That's usually a good thing, because it means the patient has cleared it out before they've gotten the next dose. It means they're not accumulating drug, it means they're less likely to have those toxicities manifest. Okay. Again, you like to check those troughs. If you're doing like a peak and a trough, say you're doing like Q8-hour dosing, you do it basically around 1 dose, where you would get a trough before the dose is given, you give the dose, and then you do peak afterwards. And because you're at steady state, you can be reasonably assured that those are going to be roughly at the same levels. Does that kind of make sense? So if I was to show you this on a graph, you know, when you're at steady state, essentially what you're going to see is that the levels stay pretty consistent. As long as there's no change in how the patient clears it, the level should stay relatively the same. So if I give my dose here, what I can do is check a trough right at this point here, and then I can also check a peak right here. And because of that, I know that this peak is going to be the same as it would have been over here before that dose. So again, I can use that information just to extrapolate and see that, make sure they're you know, handling the drug appropriately. That's if you're doing like Q8-hour dosing or something more frequent. Usually with the 24-hour dosing, we would just go ahead and just check a trough level to make sure it's undetectable, essentially. Okay. Next up, we have this oxazolidinodione, or oxazolinodione. Apologize. We don't say that very often, so we just say it's linezolid or Zyvox, the drug. This is going to be another very good gram-positive killer. So this is one of the drugs that we use as a backup to vancomycin. So if vancomycin is not working, we're going to use linezolid or Zyvox as coverage for this. So this is very good for like VRE, or vancomycin-resistant enterococcus, for vancomycin-resistant Staph aureus, of VRSA or VRSA, if you see that. And so we like to reserve this drug as best we can. Really no gram-negative coverage or anaerobic coverage. This is specifically for getting those MRSA infections that cannot be treated with vancomycin otherwise. Okay, so you'll see this a lot for things like hospital-acquired MRSA or community-acquired MRSA that's resistant. The nice thing here is that Zyvox does have an oral option. You give it IV or orally, but again, it's very expensive. We like to hold off on using this because, again, we don't want bugs to become resistant to this, because it is such a good backup drug that we have there. Interestingly enough, we do have a notable toxicity that you can see with linezolid, and that's going to be this Ssri interaction. You guys remember, I mentioned what Ssri means before. Do you guys remember? Yeah, it's a selective serotonin reuptake inhibitor. So basically, it will block the reuptake of serotonin to increase those levels. We use those drugs as antidepressants most often. And so what you can see is that this linezolid actually has some MAOI capabilities, meaning it inhibits that monoamine oxidase. And you guys remember what that enzyme does? Breaks down serotonin, right? Breaks down things like norepinephrine, serotonin, epinephrine, all this good stuff. So if you block the ability for monoamine oxidase to break down serotonin, and you also have another drug which is increasing serotonin levels, you have what we can see what we call serotonin toxicity, which you can manifest as things like hypertension, tachycardia, altered mental status, those kind of things. And so you want to watch out for that. So this is why you want to make sure that patients who are on SSRIs, they have a period of washout where basically they don't take those drugs for a period of time so that they can get their Zyvox without having any interactions there. Sometimes you can't really avoid that, and you just have to kind of treat through it, but that's one thing to be aware of. The other thing is tyramine-containing foods. Tyramine is a precursor from our diet that can be turned into serotonin, so that undergoes similar reactions there. So we can see things like aged cheeses and meats and beer and red wine, stuff like all the good stuff in life has high tyramine content. So we do recommend avoiding those foods if you're going to be on Zyvox at the same time. If you have an infection bad enough that you need Zyvox, you probably are really concerned with going to your fancy cheese parties and stuff, right? So just avoid it for a little while. So again, Zyvox, you can see here, is going to be working as a protein synthesis inhibitor. And so again, just watch out for those tyramine-containing foods, as I mentioned. We'll talk about this more when we get to the behavioral health section, probably in Pharm 2. And so this will become much more obvious there. Another drug, and I just kind of mentioned it briefly here, is called daptomycin or cubicin. This is one that is not going to work on the protein synthesis, but what it actually does is it depolarizes the bacterial cell wall and actually will inhibit DNA, RNA, and protein synthesis kind of more globally for the bacteria. So it's very, very good. It's very bactericidal. We use it sometimes for very resistant MRSA infections. Again, it's another good gram-positive killer. It doesn't really have a lot of other coverage. One of the big things we can see is it can actually cause muscle pain and muscle breakdown. So you guys remember that CPK, what that means? Yeah, creatine phosphokinase is when you see that in the bloodstream, that means that there's muscle breakdown happening there. So you monitor that CPK levels to make sure you're not having any of that. So the patient, is saying, hey, I just feel like I just ran a marathon or I've been lifting weights and I haven't really done anything. Like that's another sign you can have muscle breakdown going on there. And then what's interesting is you can't actually use daptomycin in pneumonias because the surfactant in the lungs will actually inactivate the drugs. It's kind of a unique thing where you can use it for like bloodstream infections, soft tissue infections, but you can't use it in the lungs. So it's kind of a unique thing there. Okay, up next is going to be our fluoroquinolones. So that's kind of all of most of our protein synthesis inhibitors. Next, we're going to have our fluoroquinolones. This is including levofloxacin, ciprofloxacin, and moxifloxacin. Obviously, you can tell the floxacins are going to be the fluoroquinolones. So again, you kind of learned these naming conventions that'll kind of help you keep these drugs in their categories essentially. So try to kind of pick up on those things. I'm sure most people have at least heard of one of these, like Levaquin or Cipro before. Very commonly used in the outpatient setting. Again, probably used way too commonly, leading to a lot of resistance. The way these drugs are going to work is by inhibiting bacterial DNA gyrase. Another name for this is topoisomerase 2. And basically what this enzyme does is it helps to cause single strand breaks in the DNA that will allow it to relax and either relax that helical structure or to retighten it back up. So when you're doing things like DNA reading and whatnot, you need to relax that helical structure, and topoisomerase helps with that. So if I inhibit this, I inhibit the ability for that DNA, you increase the number of strand breaks you have, increase the damage done to the DNA, and eventually it's going to lead to cell death happening there just due to triggering off apoptosis and things like that. So again, induced DNA cleavage here. And so, we don't understand the full mechanism there, but that's or at least our best guess right now is by inhibiting that, you're damaging the DNA enough to where the cell is going to go ahead and just kill itself off. So our fluoroquinolones, they have pretty good coverage for the most part, a lot of gram-negatives, good atypical coverage, and a little bit of gram-positive coverage here. So what we end up seeing is it uses a lot for community-acquired pneumonia. One exception here is we do not use ciprofloxacin. We have what we call respiratory fluoroquinolones, and ciprofloxacin is not one of those. Cipro tends to not really get good levels within the lungs necessarily. See it more kind of concentrate in the urine, so we don't like Cipro for that. But if you see it for sinusitis, hospital-acquired pneumonias, we'll use this very frequently. UTIs, however, we will not use moxifloxacin for UTI because this is one of the ones that is only metabolized within the liver, so it actually never makes it to the kidneys to be able to treat the urinary tract. Okay. So again, these are going to be renally eliminated except for moxifloxacin. You do have to monitor renal function there. Sometimes you use it for infectious diarrheas. Sometimes for the skin. Again, Cipro is not going to be very good because it doesn't have very good MSSA coverage in a lot of cases. And sometimes used for osteomyelitis. Sometimes you'll have patients who will have osteomyelitis that can develop secondary to things like ulcers that form, like wound ulcers and things like that. They're like chronically, laying down or sitting down for a long period of time. Sometimes you can see that those pressure ulcers can eventually get infected all the way down to the bone, and sometimes you'll have translocation of like gut bacteria and stuff. So when you have those kind of gram-negative like osteomyelitis, this is where your fluoroquinolones come into play here. But another big thing you want to be careful for as far as interactions go is that it can chelate to iron, bind up with calcium, things like that. So that will prevent it from being absorbed very well. Again, someone asked me earlier, if you are looking to avoid those kind of drug interactions, essentially what you can do is take the antibiotic either the hour before you were to ingest something with calcium or iron in it, or you do it 3 hours afterwards. That way you kind of avoid those drug interactions. You can have good absorption of both products. This is another one. You can see QTC prolongation. So if you were to use, say, like a macrolide plus a fluoroquinolone, you can see additive effects on the QTC. And again, the more QTC prolongation, the more at risk for torsades you are. And then another kind of unique thing here is you can see increased ultramental stats in some of your elderly patients. So sometimes this might be one of the things you avoid for the really elderly patients, because you can't really tell, is grandpa having worsened dementia, or is it because one of the medications they're taking. Okay. I mentioned warfarin. You guys remember what warfarin is? I mentioned it briefly. It's a blood thinner. It's anticoagulant. So again, this is another one of those things where you can potentially see, because you can have some effects on the gut flora. One of the things we saw is that for, do you guys remember what fat-soluble vitamin requires the gut bacteria to help with absorption? Yeah, so it's either A, D, E, or K. And which one is really important for clotting factors? K, yeah, so vitamin K is a big thing there. So if you disrupt the gut flora pretty significantly, what you can end up seeing is you have disruption of that vitamin K or absorption, and that can lead to over kind of increased effects of warfarin, more likely to see bleeding, bruising, things like that. So anytime you have a warfarin patient, you're putting them on antibiotics, always check those interactions to make sure you're not going to cause any issues there. Make sure you're monitoring the INR as you should. Again, we see a lot of overuse, so a lot of resistance associated with this, especially with those like sinusitis and things, which are mostly viral. People get given Levaquin and then get treats almost everything, and then you end up getting resistance developing for that. So again, sometimes you can see things like collateral damage, like developing C. difficile infections secondary to that, just resistant infections that are not treated by fluoroquinolones later on. So again, be very judicious when you decide to use your fluoroquinolones. You can kind of break the fluoroquinolones up based on their generation as well, kind of similar to the cephalosporins. Clinically, you're not going to really differentiate these too much based on generation, so I probably wouldn't memorize specifically which generation each one falls into, but I would at least be aware of some of the differences in coverage you can see. So for instance, we don't use a lot of the first generation fluoroquinolones anymore, but we do use the second generation, which would be Cipro. Here you're going to notice it has good gram-negative and atypical coverage. It's kind of plus or minus on Pseudomonas, and so it's one of those things we don't use very frequently for Pseudomonas because resistance is likely to have occurred. Again, be very careful with the renal dosing. Make sure you're monitoring for that to see if there's any changes you need to make, either giving the drug less frequently or giving a smaller dose or something like that. You have levofloxacin, which would be considered a third generation. Do you guys ever see the drug ofloxacin? Do you guys remember what we talked about with those enantiomers and the chirality of these molecules? This is very similar. So you see ofloxacin, this is the left-handed version of that, so levofloxacin. Basically, it's going to have increased gram-positive coverage here, and it's going to have pretty good coverage against Pseudomonas. I mentioned that you shouldn't double cover for bacterial infections in a lot of cases. Pseudomonas is one of those exceptions where you will oftentimes use 2 drugs to cover it, just to make sure you don't have any resistance to one drug versus the other, because those infections can be so severe. So this is one of the things where you'll oftentimes see like gentamicin plus Levaquin, right? Or you'll see something like Zosyn plus Levaquin or plus aminoglycoside. So because of that, you will see oftentimes double coverage for Pseudomonas. Okay, so just be aware you might see that. Again, we use this a lot for community-acquired pneumonias because it has good strep pneumo coverage and also atypical coverage. So this is why it gets frequently overprescribed for that purpose. And again, a lot of cases you'll see with a lot of like pneumonias and things like that, like just high dose amoxicillin would be fine, or augmentin. But a lot of people kind of jump the gun and go to something like a fluoroquinolone, much more broad coverage, much more likely to see resistance develop because of that. Again, renal dosing, need to be watchful for that. Moxifloxacin or Avalox, again, is going to have better gram-positive coverage, but not really a whole lot of Pseudomonas coverage happening here. So again, not covering for Pseudomonas. You oftentimes see this more used for either ophthalmic preparations or otic preparations. We'll talk about that when we get to those sections respectively. But here you may see it used in community-acquired pneumonias potentially, again, where you're not really suspecting Pseudomonas quite so much because it does have good strep pneumo and atypical coverage. Do you have a question? Okay.
Nothing like minus Pseudomonas?
Yeah, so no Pseudomonas coverage, so negative Pseudomonas coverage. That's right. Again, do not use for urinary tract infections because it does not collect in the urinary tract. It will be only metabolized within the liver. So I mentioned the side effects with the fluoroquinolones mainly being that complex with the cations like iron and calcium, so that can prevent absorption via the GI tract. Can see some photosensitivity, so it'd be one of those things where, especially here in Florida or in the summertime, so hey, just make sure you use extra sunscreen. Just be careful to because rash and sunburn is more likely to occur. Pneumonia. It's a common abbreviation. I know that doesn't seem like a very intuitive abbreviation, but PNA is pneumonia. I'll say that. See how abbreviations can get you in trouble in the medical field? I was doing that on purpose, so thank you for illustrating that point for me. Anyway, you can see some minor P450 interactions. Mainly, this inhibits 1A2. This one does not come up super often clinically. There's not a lot of drugs metabolized by CYP1A2, but again, run your interaction checker beforehand just to make sure you're not going to have any problems with that. We'll see QTC prolongation, so increased risk for torsades if you do have multiple drugs added on there. And then the other kind of unique thing with the fluoroquinolones is there's some risk, and some people actually advocate not to use this in children, but you do worry about tendinitis and also possible tendon rupture. So there's been some case reports of things like Achilles tendon rupture that can occur, and so that's why they will say, hey, use with caution in kids less than 18. We still use it occasionally, but not as often as you might see it used in adults. So just be aware of that. I'm not really sure the interaction there. It's just one of those kind of unique things you see with the fluoroquinolones. Okay, next up we have clindamycin or cliacin. This is another good gram-positive covering bug, but it also is going to be good as an anaerobic coverage as well. So again, this is going to be gram-positive aerobes. It's going to be including MRSA. So this is one of the, again, a few drugs that does cover MRSA. So far, we have things like vancomycin, we have like linezolid, we have daptomycin, now we have clindamycin. Again, it's going to be decent coverage against some MRSA strains. This one is going to have good activity against anaerobes. It's another kind of unique point that we will use it for very frequently is for the anaerobic coverage. No gram-negative coverage here at all, though. So if you need to, if you're worried about gram-negatives, you need to use a different drug or use something else in addition to this. Some other things you may see this being used is toxin-mediated diseases. So if you guys ever heard of toxic shock syndrome? Yeah, sometimes some of these infections will release exotoxins, which can lead to very severe inflammatory reactions. And so you can actually use clindamycin to bind up some of those exotoxins and prevent that big kind of inflammatory cascade. So this is one time where you'll see it used not for its anti-infective properties, but because it can interact with those exotoxins. Uses it very frequently for skin and soft tissue infections. For osteomyelitis, you'll see this very frequently for treating things like cellulitis or abscesses. And sometimes we use it as an alternative for surgical prophylaxis. So if you can't use like cefazolin, you can use something like clindamycin instead. Okay, and also we may use it for in combination with other medications for intra-abdominal coverage. So this would be a case where clindamycin is good for the anaerobic coverage, and use something else that will cover gram-negatives. So sometimes you can see two drugs being used to cover different types of bugs. Big side effects you're going to notice here. The biggest one is that the clindamycin, because it is such a good anaerobic killer, is able to disrupt the GI flora, and so C. difficile is going to be probably the highest risk is seen with clindamycin. So if you notice, definitely warn your patients about diarrhea, but say especially, hey, if it becomes especially watery, sometimes we'll talk about like a rice water kind of diarrhea, which is kind of a gross description of it, but pretty apt. Very foul smelling, like that could be a sign of C. difficile. They may need to come in and either get probiotics, or they need to have treatment for that with either oral vancomycin or another drug we'll talk about just a little bit there. And the eventual complication of C. difficile is going to be the pseudomembranous colitis, which is a very, very severe kind of inflammation of the colon that can occur. It can be very, very difficult to treat and can be very bad for your patient. So next up, we have sulfamethoxazole and trimethoprim. And so these are going to be drugs that are given in combination. They have kind of synergistic activities to inhibit bacterial action. And so if you guys ever heard of Ceftra or Bactrim, another very common, not over the counter, but very common outpatient antibiotic you might see out there. Basically, we're giving it as a combination of sulfamethoxazole and trimethoprim. You're going to see they have synergistic activity here where the sulfamethoxazole, which you'll sometimes see abbreviated as SMX, will be inhibiting this conversion of para-aminobenzoic acid, or PABA, to dihydrofolic acid. Okay, basically this means basically this whole process here is preventing the bacteria from generating folic acid or utilizing folic acid, so that way it cannot be used to generate things like DNA, right? Because we saw that folic acid is really utilized very frequently in generating new base pairs for producing new DNA. Trimethoprim is going to work a little bit farther down the process here, where it actually will inhibit conversion of dihydrofolic acid over to tetrahydrofolic acid. And so if you can't utilize that, then that's leading to inhibition. Can't really produce things like thymidine and other types of nucleic acids. So again, working on two steps of the process here to have some synergistic action. And there's another drug we can use that is kind of similar to trimethoprim that we use for people. You guys ever heard of methotrexate? Yeah, so it's a drug we'll sometimes use for rheumatologic conditions or for cancer that will work on this similar pathway. But again, it's specific for people versus trimethoprim and sulfamethoxazole being specific for bacteria. So Ceftra or Bactrim has pretty good coverage against things like, you can get some strains of MRSA being covered with Bactrim, things like strep pneumo, listeria, but again, like similar to the Cephalosporins, does not cover Enterococcus. It'll also cover a lot of gram-negative aerobes. Pretty good coverage here. You notice here this Burkholdia, Cepacia, and the Stenotrophomonas multifilia. You have to memorize those specifically, but those are some late-stage cystic fibrosis bugs that those kids tend to get, and so this is why you see a lot of Bactrim being utilized in those patients. The other big thing is it is very good at working against some of these opportunistic infections that you can see in some of our cancer patients who are neutropenic, or some of our HIV/AIDS patients as they get more progressive. So things like Pneumocystis carinii, Toxoplasma, Nocardia, you'll have some coverage against that as well. And so in some cases you may see like HIV/AIDS patients, or you'll see these cancer patients, as they become more neutropenic, they'll actually be put on Bactrim as prophylaxis. So to prevent one of these infections from taking root in the first place, they'll go ahead and give this to them, say, a couple times a week, and prevent that from taking place. So again, so this is probably the other name for it. So if you ever seen like Pneumocystis jirovecii, that's probably the more common name for it nowadays. So like a PJP pneumonia said that Pneumocystis carinii. This is the more up-to-date nomenclature. So you can use it for treatment and prophylaxis of that. Use this a lot for UTI. So I'm sure a lot of people have ever seen someone who has been on Bactrim for a UTI before. It's a very common antibiotic for that, because it covers things like E. coli, Klebsiella, and all these other kind of more common species. We'll sometimes use it for respiratory tract infections, not super common, and more often you'll see used for GI infections as well. So things like traveler's diarrhea due to E. coli, enteritis due to Shigella. Those are some common places you'll see that. Okay. As far as adverse effects go, so you do want to be careful. You can see some hypersensitivity. And did I mention the Stevens-Johnson syndrome, the toxic epidermal necrolysis? This is another common one. You can it's not common, but it's one of those things where you want to warn your patients, hey, if you see new rashes or blisters, like, hey, you need to come get that checked out immediately, either at the ER or at the clinic, wherever. So be aware of that and educate your patients on that one. And then you can also see some risk, and because it is affecting the ability for the bacteria to use folic acid, there is, again, selectivity is only going to go so far. So there is a little bit of bleed over, and you see a risk for things like megaloblastic anemias, things like that, which can be related back to that folic acid deficiency. Other things, you can see some drug interactions where it's not necessarily through, there's a little bit of CYP2C9 inhibition here. So again, another type of CYP enzyme we're going to see inhibited that will increase levels of things like phenytoin, rifampin, digoxin. Phenytoin's an anti-epileptic. Rifampin's actually another antibiotic we'll talk more about when we get to the cardio section, and then digoxin's a cardiovascular medication. But you can also see things like decreased renal clearance of drug methotrexate, or MTX. This can lead to pancytopenia. Don't really memorize this so much, because we'll talk about it more when we get to cancer treatment. When we get that. And then you can see increased hypoglycemia with some of our anti-diabetic medications, and specifically our sulfonylureas. If we really haven't covered these drugs yet specifically, I'm not going to have you memorize those examples. Just be aware that you will see these drug interactions. Check your interaction checker before prescribing these drugs. I'll never forget one time when I was on rotations. My very first one was at an ambulatory pharmacy that had a warfarin clinic. And so one of the things that pharmacy students will frequently do is operate a warfarin clinic. Probably not so much nowadays, since we have a lot of newer oral anticoagulants, but warfarin used to be king for that for many decades. And so essentially what I would do is a patient would come in, I would check their INR rate, nice little point of care testing, and I would adjust their dose, right? And so I would basically we had a protocol set up with our docs so that I could do that, have it signed off by my pharmacist, and the patient had their new dose, right? And so one time we had one of these patients I'd been following for a while, finally got his INR all checked out, and then he came in and he was filling a Bactrim prescription. No one actually caught that interaction there with the warfarin and the Bactrim. And so I had one of the nurse practitioners come up later, and they're like, hey, did you know that you guys let this go? And immediately I was like, oh no, what happened? What is his INR? And they're like, the INR was 17. I'm just like, wait, that's high. That sounds a little too high. You're joking with me? And they're like, yeah, I'm just kidding. It was fine. I was like, oh. So be careful with the warfarin. Be careful. Look for those drug interactions, because again, if their INR goes up too high, like, they can have very serious, brain bleeds. They can have all kinds of really bad bleeding there, and you really want to avoid that. So just be careful. Don't screw up like I did, right? Okay, so next we have metronidazole, or Flagyl. This is another common antibiotic we'll see being used sometimes for parasitic infections. Actually, sometimes you'll see it used for some infections used for anaerobic coverage as well. So it's kind of the two main uses for parasites and for anaerobic infections. This is actually affecting the bacterial DNA, will cause it to lose its kind of helical structure, and you see a lot more strand breakage happening there. So again, damaging the DNA to a point where the bacteria just goes ahead and offs itself. Very good anaerobic coverage, good parasitic coverage, but not really coverage for anything else. So it's pretty narrow spectrum. In a lot of cases, you'll see this being used as something else to help provide extra coverage. We use metronidazole most commonly when we are dealing with patients going for appendectomy because we're worried about those gut bugs and potential leakage of those in the intra-abdominal space, we'll actually use ceftriaxone or Rocephin along with metronidazole. That way we have anaerobic coverage and we have our good gram-negative coverage. So sometimes you'll see things like that being done. So this is also the drug of choice for C. difficile. So Clostridium difficile infections, this is going to be the first drug you use. You guys remember the other drug I mentioned you can use? Yeah, vancomycin is going to be the other one. So this one's interesting because you can use the IV or PO, which means basically you can end up seeing that even if you give it IV, there's enough local concentration at the site of the GI tract to still treat that infection. So you can utilize that, or PO if the patient's able to tolerate that. So it's good. Intra-abdominal infections, certain sexually transmitted infections can also be treated with metronidazole as well. We'll talk more about that later when we get to kind of the HIV section, I think. Another side effects to watch out for, there's kind of a unique one we call a disulfiram-like reaction. So does anyone know why? So alcohol metabolism, I've kind of mentioned this before, undergoes kind of a two-step process where basically it gets broken down by this enzyme called alcohol dehydrogenase, and it gets turned into a product called acetaldehyde. And then that acetaldehyde gets broken down by an enzyme called acetaldehyde dehydrogenase, and then eventually gets turned into water and carbon dioxide, and you can get rid of it, right? So what you end up finding is that certain drugs are able to block the actions of the acetaldehyde dehydrogenase, that second step, and so you end up building up levels of this product called acetaldehyde. And this is what makes people feel very sick. They get very flushed, they throw up. Certain people of Asian descent tend to have deficiencies in this enzyme. So if you ever see someone talk about like the Asian flush, that's usually what they're referring to, is they lack that enzyme. And so certain drugs can do this as well. So disulfiram is one of the ones there. We used to give disulfiram as an alcohol deterrent because we would give it to patients who are alcohol dependent. They would drink alcohol, get really sick, and then hopefully not ever drink again. Obviously.
Sorry, I mean, is that Antabuse?
Antabuse, yeah, is the brand name for that drug. Obviously, the compliance isn't super good because if I'm an alcoholic, I'm just not going to take that, right? And I'll just keep drinking. But what we can see is that some other drugs can have this action as well, and some metronidazole is one of those ones. So if you ever hear like, hey, don't drink with this medication, this is usually what they're referring to, because you can end up seeing increased risk of nausea, vomiting, flushing, just feel really, really crummy, right? Okay, next couple ones we have here, Polymyxin B and Polymyxin E. You see these used much more frequently on the topical side. It's just a lot in like your either otic preparations for ear infections, or you'll see them being used for topically for things like Neosporin, those kind of triple antibiotics. They usually include the polymyxins. These are basically, they work by kind of punching a hole through the outer membrane of these gram-negative rods in a lot of cases, and by punching a hole through, they kind of lyse open the cell and cause leakage of these contents. Very, very potent drugs, very good broad gram-negative coverage, and so this is one of the things, kind of the unfortunate consequences of antimicrobial resistance, is because we have certain gram-negative bugs that are so resistant nowadays, everything else doesn't work anymore, and now we're having to resort to using really very toxic drugs like polymyxin B and E. It's fine if you use it topically because you don't get a lot of systemic absorption. Problem if you're having to give it IV. And so we had to use this in a few cases, at least that I've seen. And basically what you end up having is that a lot of neurotoxicity and a lot of nephrotoxicity can happen. But again, if it's either the patient's dead or I'm going to hurt their kidneys, you kind of have to choose, one or the other. And so usually err on the side of going and treating the patient in a lot of those cases. So again, a lot of black box warnings associated with these drugs, especially in the nephro and the neurotoxicity. So we don't like to use them, but you may see it used occasionally for those really severe multi-drug resistant kind of infections. But again, topically in the ears, totally fine. We'll talk about a little bit of risk when you use it otically in just in a couple slides, or in a couple lectures from now. But we'll see that come up again. Okay, so that's it for our antibiotics. Everyone feel pretty comfortable with those? Okay, repetition is the name of the game. So we'll talk about these again and again. You'll talk about these in other courses, so don't feel too overwhelmed just now. But again, we'll have a nice review, kind of cover what kind of questions I'll be asking on the test later on. So don't feel too overwhelmed at this point. That can come later, right? All right. We'll talk a little bit about antifungals real quick. So obviously, having a fungal infection is a lot different than a bacterial infection because of the fact that their structures are so different, right? So what you end up seeing is that for these fungi, these mycoses, you're going to have this kind of rigid cell wall containing this chitin kind of see this kind of rigid cell wall. And how the cell membrane contains this ergosterol. So you kind of see the cell membrane, see the ergosterol is going to be located here. And so we have a lot different targets than we would see for bacteria. So we need to have totally different classes of drugs in order to treat those. They have different ribosomes. They have distinct nuclear membrane. So again, that can be more difficult to penetrate in some cases. And they really don't respond well to antibiotics. We need antifungal agents in order to treat these. So, fungal infections are not super common, at least the really clinically significant ones. But some reasons why you may have a fungal infection that can develop is due to things like loss of barriers. So if you have, large amounts of skin being lost due to things like burns, surgery, if you have like indwelling catheters or hardware like that, that can be a risk for developing a fungal infection. If you have immunodeficiency, a lot of our HIV patients have organ transplant, because again, oftentimes you keep patients who have a foreign organ in them immunocompromised to prevent them from reacting and rejecting the organ. Chemotherapy, all of those sorts of things. It can lead you to have a fungal infection. And a lot of times what you see is for these patients with really severe cancer, it's not necessarily the cancer that kills them, it's the fact that we've treated them with chemotherapy, knocked out their immune system, and then they get a secondary infection due to a fungus or something like that. It's oftentimes what we'll see a lot of these patients end up succumbing to, unfortunately. Sometimes you can see certain metabolic abnormalities, so like diabetes. If you're keeping the blood nice and chock full of sugar, things like to grow in those kind of sugar-filled mediums, and so you can see more risk for fungal infections. Sometimes what you can see is if you knock out the normal flora in a given site, sometimes you can actually see these opportunistic fungus will come in and develop a secondary infection. So that is a risk there as well. And then any kind of moist, warm environment, so things like athlete's foot, diaper rash, is probably where we're going to see these more commonly on the outpatient side, is where we're going to see these develop. So again, most often they're going to involve the skin, but they can be systemic. And once they become systemic, they can become very, very difficult to treat. A lot of the drugs we use are very, very toxic in a lot of cases. We'll look at those just as we move forward. Okay, so again, systemic mycoses are these internal organs, the type of normal funguses we're going to see. And again, I'm not going to get real specific on asking which drug covers which kind of fungus. Just know, hey, as a group, they're antifungals. But things like aspergillus, blastomyces, candida, you'll see these come up pretty frequently. And a little bit different spectrum of fungal infections that occur if they're dealing with just like say the skin layers, or if you're doing things like the hair and the nails and whatnot. So again, it'll change a little bit based on where the actual site of infection is as to what type of fungus you're going to use, and that will change what type of drug you're going to use as well. So overview of the drugs. Here's kind of the different classes we're going to talk about as we move forward. So I'm just going to go ahead and get to them at the ground running, so to speak. Okay. So looking at cell wall active antifungal agents, so we're going to have certain things that will affect the cell wall. So we have the polyenes we'll talk about, and these are going to help to alter that membrane integrity, increase permeability, and they'll actually inhibit that ergosterol synthesis. So by inhibiting ergosterol synthesis, you end up having degradation of the cell wall for the fungus and have leakage of contents there, very similar to what we saw with things like our beta-lactams. We have azoles, which are going to inhibit ergosterol synthesis by inhibiting this lanosterol demethylase. And then we'll have the allylamines are going to work on a different enzyme, squalene epoxidase, and again, all working to inhibit ergosterol. That's kind of the main takeaway. These are inhibiting ergosterol synthesis. You're degrading the cell wall. And then we'll also see another one of these echinocandins we'll talk about just a little bit. These are affecting the D-glucans, and it also will affect cell wall synthesis as well. So certain drugs can affect cell division. So the griseofulvin, which is probably going to be a very common one you'll use in the outpatient setting, will inhibit the actual microtubules. So you guys remember the microtubules are very useful for pulling the DNA apart during cell division. That gets inhibited here. And then we'll also have some drugs that can affect actual nucleic acid synthesis. So things like flucytosine will actually be converted to 5-fluorouracil and will actually prevent uracil from, or thymidine from actually being made in the DNA there. One of the first ones we'll talk about specifically is going to be this one called amphotericin B. A lot of people call this amphoterrible B because it is such a toxic drug. This one is going to be working to form these channels in the ergosterol membrane that allow for things like electrolytes to end up leaking out of the cells. And you're going to start to see this actually is not completely specific for funguses. It'll actually affect human cells as well. So again, imagine basically the ergosterol here in the cell wall. The drug can basically open a pore there for contents to leak out. You can kind of see how that would kind of do that based on kind of the planar structure there. How it can kind of interject itself into the ergosterol. So amphotericin B, we use this for systemic fungal infections. It is very, very toxic, not only to the fungal cells, but also to us, especially with a lot of nephrotoxicity. It can cause a lot of electrolyte wasting, a lot of issues there. And so we do things in order to make it more tolerable for the patients. We change the dosage form. So this is an example of a product called Ambizome, which is contains amphotericin B, where basically you have this kind of lipid bilayer. Kind of see the cross section there, the bilayer, and they impregnate the bilayer with molecules of amphotericin B. And for whatever reason, due to being more lipophilic, it tends to not have as much effect on human cells, and so you see a lot less toxicity with it. It tends to be more expensive, but just know there's different formulations that are trying to reduce that toxicity. Use it for a wide range of different types of fungal infections. And again, you see a lot of side effects. A lot of it is related back to some of the effects it has on things like interleukin-1 and tumor necrosis factors. So you can see a lot of fever and chills associated with that. So a lot of times what we'll end up doing is pre-treating these patients with things like acetaminophen. You guys know what acetaminophen is? It's Tylenol, right? So it's an anti-fever drug. Some antihistamines like Benadryl or diphenhydramine, and then corticosteroids will also help to kind of tamp down that reaction there. So the big side effects we see with amphotericin B include things like electrolyte abnormalities because of the effects it has on the kidneys. Again, opening up some of these channels and causing hypokalemia, hypomagnesemia. Hypotension can happen here. Uremia, decreased filtration. So really just wrecking the kidneys for the most part. So we do things like try to hydrate the patient as best we can. So give them lots of saline beforehand to try to flush out the kidneys and try to flush the drug away. But again, not always going to be possible to block that. So also, we have another drug here called nystatin. This is actually going to be in the same category as amphotericin B, but the nice thing here is it's not really a systemic acting drug. It's much more going to be used topically because it doesn't actually get absorbed from the GI tract. So if you ever seen nystatin, it's a pretty common one we see used in the over-the-counter, not over-the-counter, but in outpatient type settings there. We also use this for oral candidiasis. You guys know another name for oral candidiasis? Yeah, thrush. Have you ever heard of thrush? Like, that's basically what we're treating there. So if you ever see like this kind of fungal plaques in the back of the throat, that's thrush. You can use it or treat it with nystatin there. And the nice thing is the patient can either swish and spit, or they can swish and swallow. It doesn't really matter because the drug doesn't get absorbed to the GI tract. Okay, next we have that 5-fluorocytosine. Basically, you're going to see flucytosine is another name for it, basically the same, two names for the same thing. I mentioned, again, this is going to inhibit DNA and RNA synthesis within the fungus, and sometimes you use it for more of these systemic and fungal infections. Again, not used super commonly. Again, more used if some of these other drugs have been proven ineffective. So again, just kind of including here for completeness sake. What you see is, and again, there's not 100% selectivity for dealing with the fungus versus dealing with people. I guess we're more like funguses than bacteria. I don't know. I am a fungi. Some people have said so. Had to get that one in. Anywho, but what you can see is because it's affecting the DNA synthesis in the fungal cells, it also can affect us as well. So this is where you can see things like bone marrow suppression. This is where you're going to have a lot of these rapidly dividing cells get affected. So your immune system takes a hit. You see GI disturbances as you start to lose some of those cells there as well. So those are things to watch out for. And again, this is why we do not use it super commonly, but only for those kind of more resistant infections that are not really treatable by much else. Okay, this group is going to be much more commonly seen being used, and so this is going to be our imidazoles and triazoles. These are actually inhibiting fungal CYP450. So this is actually, the fungus has their own CYP450 system that they use to help produce their cell wall, and so by giving these drugs, you inhibit that conversion of a product called linosterol into ergosterol. And so this is going to have a good treatment for things like Candida, Cryptococcus, all these different ones. And so the most common type of infections you'll see from this include things like tinea pedis or athlete's foot, tinea corporis or ringworm, jock itch, onychomycosis or nail fungal infections. And so a lot of these drugs will be able to be used to treat that. So some of the ones we'll see include things like ketoconazole. So this is going to be an oral medication, usually taken with meals to kind of help with absorption there. Some of the things you'll see is that some of these will cross into the CNS, some of them won't. That can be important if you have a CNS fungal infection, which if you have one of those, you're doing pretty bad for the most part, but that can be clinically important for in some cases. Also, this is available topically, so you may see that being used pretty commonly as well, especially for some of these kind of superficial fungal infections. And the big thing to know here, if you're taking it orally and you're getting systemic absorption, is because it's affecting the system for the fungus, it also is affecting us as well. So one of the big things you see is the CYP3A4 inhibition, leading to very significant drug interactions are possible, right? So just be aware of that. Be careful when prescribing these azole drugs, because they, for the most part, can cause a lot of CYP interactions. We have itraconazole or Sporanox. This one is kind of replacing ketoconazole because there's a little wider spectrum of different fungus that it'll treat. And again, it'll be another inhibitor for CYP3A4. So you do run into drug interactions there. And this is another one that's actually teratogenic. You guys know what that term means? Yes, it's harmful for a developing fetus. So this would be one of those things we do not give it to pregnant women because it's teratogenic. So you see that term, it's going to refer to specifically negatively affecting those fetuses. Posaconazole or Noxafil, this is again another triazole. It's kind of related to itraconazole, but it ends up being even more potent for some of these enzymes here. And so, again, just wider coverage against a lot of these different types of fungal infections. This one's kind of unique because it does cause some QT prolongation. So will be one thing you want to watch for. I ran into this problem dealing with some of our a patient who had a bone marrow transplant. We had to keep them very well immunosuppressed because we did not want their bone marrow graft to be rejected. And so they were developing a fungal infection. And so they happened to be on a bunch of drugs that caused QT prolongation from the immunosuppressive side. And then we put them on posaconazole and saw increased QT intervals. So that's one of those things you really want to watch out for there. Then we have fluconazole. This is probably one of the most common antifungal agents you're going to see. Has anyone ever heard of diflucan or fluconazole? One of the more common ones you'll run into. So this one has really good oral absorption. This one can also be used in the CNS. So if you have like cryptococcal meningitis for like something like your really kind of end-stage AIDS patients, you may see that potentially. And sometimes we'll actually give it as a preventative agent in certain AIDS patients. So once their CD4 count gets low enough, we may give them fluconazole to prevent any kind of infections. Because the thing you run into is even if you had something as simple as a thrush infection, you know, most healthy people can fight that off pretty easily. But for some of these patients, that can become systemic, and that can become a very big problem. So if you see thrush in a patient who's neutropenic, that can be a problem, right? So which is why we will oftentimes give them prophylactic nystatin to help kind of deal with that thrush issue. Sometimes we'll give them fluconazole. And again, CYP3A4 inhibitor, also 2A4. 3A4 is probably the more clinically important one there to note. So just be aware that is going to be lots of drug interactions associated with the azole drugs. Also, you may see this being used vaginally. If you ever have like a vaginal candidiasis, this can also be used as well. So if you ever have like a diflucan tablet, it can actually be inserted intravaginally and be absorbed there for very kind of local high concentration effects. Next we have voriconazole, and so another name for this is VFIN. This is actually a derivative of fluconazole and is very, very effective against lots of different types of fungal infections, and is actually nice because it's starting to replace amphotericin a little bit. We mentioned amphotericin having so many toxicities, so this one's nice because it's starting to replace some of that. Again, we'll inhibit a lot of these P450 enzymes, so 2C19, 2C9, 3A4. So again, this will come up more later when we talk about things like anticoagulants. 2C9, 2C19 are important for warfarin metabolism. Other things you can see, potentially patients can have some effect on their vision, so you want to do a visual acuity before you start giving this and then afterwards. And if they have any new complaints of visual changes, you want to investigate that because it could be related back to this voriconazole, so be aware of that. What's also interesting is we have issues. So normally we like to give this IV. Give it PO. IV, in order to keep the drug into solution, we have what we call a cyclodextrin, which is kind of this kind of circular shaped kind of molecule that the drug kind of fits right into the middle of. You guys ever used Febreze before? You notice how like you spray Febreze and something smells good for a while and then the smell comes back? Febreze is basically a cyclodextrin, where basically it will grab whatever smelly molecule that you're trying to cover up was. Guys probably knows more because I feel like guys use Febreze pretty regularly. If you're a bachelor, you don't have a nice wife to do that for you. Anyway, so it'll bind up the smelly substance, and then it'll eventually the cyclodextrin will decompose, and then you have the smelly substance still there. So you really should just clean up your mess, if anything. But this is kind of the similar thing. To try to get the drug into solution, use the cyclodextrin, but you can have buildup of that in renal failure, which can lead to some toxicity. So I like to use PO whenever possible. Okay, so then there's a big list of topical agents that we can use that fall into this imidazole or triazole category. And so these are a lot of the common over-the-counter preparations you may see. So if you imagine things like myconazole, like monostat, use it a lot for vaginal candidiasis. You see things like clotrimazole, so Lotrimin. You're probably more seeing a lot of the brand names here, kind of familiar with those than you are the actual generic names. So things like Vagistat. So again, these are all fitting in the same category. Because they're given topically, they don't really cause a similar systemic side effects. You don't really worry about CYP3A4 interactions like you would for something like fluconazole. You really lack a lot of those, which is a nice thing there. So just be aware if you see these, the azole name, like your chances are it's going to be one of these fungal drugs we're talking about. If I had to say, so let's just say, because I don't want to have you memorize every single one of those, that's kind of mean, I feel like. You guys already have to know all the antibiotics. I would say if you had to remember anything, probably do the clotrimazole, the myconazole, and then the teoconazole. Those are probably the most likely ones I'll ask about. But just be aware. Again, if you're looking for the azole kind of name, like you just kind of know that that's probably one of these azole antifungals. From my old age. Anywho, looking at the next group. Yes, ma'am.
So you're saying most of the azoles are different.
Those ones are given topically. So you'll see most of the other ones are going to be more systemic, either PO or IV, you mentioned. So just because a lot of those, the topical ones, those are they have over-the-counter preparations you can give, and so it's, it can be useful for some of your patients to use for, kind of more superficial, easy to treat infections.
Is there any relationship between metronidazole and
There is not that I'm aware of, because you can't really use metronidazole for any type of fungal infections. You'll see metronidazole sometimes used for vaginal infections, but that's more for different types of infections there. Yeah, so sometimes you'll see them being used, but there are different types of infections you're treating. Yeah, but yeah, good question there. Yeah, so again, there's always exceptions to the rule. So just because you see azole does not necessarily mean it's going to be antifungal. Remember, metronidazole is a little different there. Okay, I'll go ahead and cut it there. Do you have any questions before I let you guys go? Yes.
We talked about the one drug being strategic.
Mm-hmm.
And then there's the other side that said animal strategy. Are we only concerned with that one that you specifically mentioned?
Just be aware of it. Just as a point, we'll talk more about tritogenesis later on, especially into like the women's health, reproductive health kind of section. We'll talk about pregnancy categories and things like that. So just be aware. Just know what the term means. I'm probably not on a test question going to ask you specifically which one of these is tritogenic. This kind of outside of the scope of our class here. Yeah. Any other questions? All right, I'll go ahead and let you guys go, and then next time we meet, we'll continue with it. We'll finish up this section and then move on into the derm section. That one should be relatively short, so we can get through pretty quick. All right, thanks a lot.